talk to you about new models of HIV care, theories, models, and promising practices. An overview of this presentation, we're going to first talk about definitions and background. We're going to talk about why new models of care are needed. Third, we're going to talk about current evaluation efforts. And fourth, we're going to talk about next steps and further considerations. We'll start with definitions and background. So some questions to start us off. What are common models of care, and what is practice transformation? Our first model of care that we'll look at are FQHCs. So our first model of care is FQHCs, or Federally Qualified Healthcare Centers. These are also known as community health centers. They were established under the Public Health Service Act of the U.S. Department of Health and Human Services. They've been in existence informally for over 40 years, but the term was first used in 1989, and then they were added as a Medicare benefit in 1991 and as a Medicaid benefit later. To be an FQHC, you must be located in a medically underserved area, offer a sliding fee scale, and then you must be governed by a board of directors with the majority of members being clients of the FQHC. So in Texas, there are 73 FQHCs. There are 3 lookalike centers, which have all the tenants of an FQHC but don't receive the same funding. And that means there are primary services in over 494 sites in over 90 counties across the state. And that's roughly 5 million patient encounters every year. I want to make a distinction between FQHCs and AIDS services organizations, because later I'm going to talk about practice transformation, which is when an AIDS services organization transforms its practice to become an FQHC. AIDS services organizations are non-governmental organizations that provide services related to the prevention and treatment of HIV/AIDS. So they target the social determinants of health. They can help patients or clients with financial, housing, food, education, testing, treatment, and prevention. They can house behavioral health services, and they can offer support for partners and families. Historically, they've been a safe place from stigma and the lack of cultural competency that plagued the traditional healthcare and medical field when AIDS first arrived. Staff can include case managers, counselors, peer counselors, social workers, treatment educators, community health workers, volunteers. FQHCs house various healthcare providers and provide medical services, and so this is a list of different healthcare providers that might be at an FQHC. But FQHCs and AIDS services organizations can be co-located, or they can be have a close working relationship. I think it's important to note that there can be fragmentation of care when patients go to an AIDS services organization, but they don't have clinical services there, and then they have to be referred to a clinic outside. That can present barriers in transportation, barriers to stigma, and can lead to fragmentation and worsen health outcomes. So we're going to talk about models in which the two are integrated. So this slide is really the pillar of primary care. This is a model that was proposed in the early 90s and set out what primary care was all about. And so there are four pillars proposed by Barbara Starfield. First, contact care, continuity of care over time, comprehensiveness, and that means care for the entire patient rather than one organ system or specialty, and then coordination with other parts of the healthcare system. And so this is a theoretical model. It doesn't give a clear practice-based or operationalization of the care model. And it transformed over time into these 10 building blocks of high-performing primary care, which you can see on the right hand of the slide. From those 4 pillars of primary care came the patient-centered medical home. This was put forth in a 2007 joint statement developed by 4 professional bodies of physicians that represented over 300,000 physicians across the country, and they set out 7 principles to describe the patient-centered medical home. And it's really the centerpiece of national efforts to reform the U.S. healthcare system and improve the value of primary care. So we'll talk about the 7 principles of the patient-centered medical home. The first tenet is that there's a personal physician. So this personal physician is the first point of contact who provides continuous and comprehensive care. The second tenet is that it's a physician-directed medical practice, but it's actually a team. And so the physician directs a team of different kinds of healthcare providers to provide care. The third tenet is that it has whole person orientation. So it provides for all the patient's healthcare needs, or it takes the responsibility for coordinating care if that patient needs to go to a specialist or outside of the primary care setting. The other part of whole person orientation is that it includes all stages of life. So it could be acute care, chronic care, it can be preventive services, and then it also addresses end-of-life care. The fourth principle is care coordination. So in the complex healthcare system, the primary care physician and the patient-centered medical home, they arrange and integrate and help the patient navigate that system. And they also help the patient's family and community in that system as well. And so this takes the form of health information technology and health information exchanges to share patient information across the healthcare system, and also includes culturally and linguistically appropriate care across all of the healthcare system. The fourth principle is quality and safety are the hallmarks of the patient-centered medical home. This means that the practice and the physician are the advocates and supporters of the patient. Also, the patient and the provider have a robust partnership, and this means that there's active decision-making between the physician's patients and the patient's family, if necessary. Another hallmark of quality and safety is using evidence-based medicine and clinical decision support tools in the clinical setting. And then there's always continuous quality improvement, so ongoing performance measurement and improvement in the clinic setting. The sixth principle is enhanced access to care, and that means open scheduling, expanded hours at the clinic, and new options for communication between the patient and the physician, between the patient and the medical team, between the physician and any outside care that they're coordinating. And then the last principle is that the payment model of the clinic recognizes the added value of the patient-centered medical home. And what that means is that there's compensation outside of the face-to-face visit between the provider and the patient. So that if you're coordinating care, if you're doing case management, if you're doing follow-up and charting, and you're making measurable achievements, all of those things are compensated in the payment model. So these are the principles of the patient-centered medical home. Much harder to implement in a clinic setting, and that's really been the challenge in primary care and in clinics that want to transition to taking on this model. It's a very difficult model to implement, and that's been one of the criticisms. So a lot of times it really takes facilitation and support from outside entities to help clinics transition to this model. The next model of care is patient-centered care, and this is not it's not a model necessarily for implementation. It's more of a viewpoint that a clinic can take, and it has very practical evaluation questions that a clinic can use and providers can use in order to evaluate how they're doing. The first tenet of patient-centered care is the patient point of view. And so looking at the patient's satisfaction with care, not just what the provider or the clinic did or didn't do. And so that focus is not on how did we do as a clinic or how did we do as providers, but the focus on how are you and how is your health improved, how is your quality of life improved, especially as it's defined by the patient and not by the provider. Another question would be, have you been able to better manage your condition and have you been able to achieve your goals? There's an emphasis on provider evaluation, so the provider evaluates themselves on the patient's outcomes. So they look at comfort. Have they been able to reduce or eliminate pain or suffering? Have they been able to produce calm in the sense that the patient's able to function in life beyond the illness? And what kind of outcomes are there for the patient? And this is beyond the clinical. Are there personal quality of life metrics as set out by the patient that have improved? The third tenet of the patient-centered care model is that you focus on what the patient's experience is outside of the healthcare setting. So it's this idea of the unobservable challenges and barriers that a patient may face. The main question to ask is, what is the reality for this patient beyond their clinical presentation, and what is hindering them in their ability to manage their disease? So some things that you could think about are social determinants of health, the current vulnerabilities they face. Do they face food insecurity, financial insecurity? What other comorbidities are they facing? What other illnesses are they dealing with? Do they have behavioral health issues? And then what's the social ecology or the setting in their social environment outside of the clinic? And this really gets at the last idea, which is unarticulated and unmet needs with unimagined solutions. This is the sense that if the patient hasn't articulated the things that they need, then you as a provider cannot help them meet those needs, and you can't work together on solutions. So just questions that you could ask are, what concerns, hopes, barriers, obstacles does the patient face in the daily management of their health? And what gaps do they encounter in their daily routine when they access healthcare? And these last questions are just a model for the providers to do ongoing reflection using patient input. So what are we doing here that's working? What are we doing here that doesn't make sense? And what are some easy ways or simple or low-cost ways that we could fix this? The next model of care is patient-aligned care teams, or PACT. This is a Veterans Affairs, Veterans Health Administration model, and it's basically their branding of the patient-centered medical home. And it's been rigorously evaluated within the Veterans Administration, and it's shown improvements in veteran access to care, satisfaction with care, healthcare outcomes, and costs. It's been specifically very successful in HIV patient care. Improvements in linkage to care and retained in care and viral suppression are at 80% or above in their patient populations. And if you know anything about the general population with HIV, it's much higher. So they're showing very good outcomes. And part of this is because they're using the patient-centered medical home, and veterans are receiving all of their care in one place. Another model, and this will wrap up our primary care models, is the chronic care model. So this is an old model, started in the 1990s. It received support from the Robert Wood Johnson Foundation to plan, refine, and evaluate it. And they came up with the model that you see there on the left of the screen. And it came about to address 4 deficiencies in chronic care. And those deficiencies were that practitioners were rushed and they were not following the established practice guidelines. There was a lack of coordination of care and planned care. There was a lack of active follow-up to ensure the best outcomes, and then patients weren't adequately trained to manage their illness. So if we go through the model on the left side, you can see that there are 2 spheres, the community and the health system, and the health system sits within the community. And then there are 4 elements in that health system that determine outcomes. So there's self-management support, delivery system design, decision-making support, and then the clinical information systems or technology that are used in the clinic. And basically, all of these work together to produce the interactions that happen between the patient and the practice team. And our last model that we'll talk about that's existing is telehealth, and it's something that is integrated within primary care practices and specialty care practices. So telehealth has emerged over the past decade to become really important, especially in rural areas and in areas where people have a lack or barrier to transportation. It has to include video chat, it has to include a high-definition camera and video screen, and it has to be 100% secure. It reduces travel time and issues with transportation. It can reduce exposure to stigma. Patients can stay with the provider that they have a relationship with, and it can improve the efficiency and timely access to care. And both the Texas Medical Board and the Texas Medical Association have helped write the rules and regulations for telehealth. And you can find more on their websites. I'm going to turn now to emerging models of care. And these are some exciting models that are showing as promising practices in improving HIV care in Texas. So we'll start with practice transformation. And practice transformation is a HRSA term, and it's defined by the AIDS Education and Training Center as a process of change in the organization and delivery of primary care to advance quality improvement, patient-centered care, and characteristics of high-performing primary care. And it goes on. In order to improve patient outcomes along the HIV care continuum by integrating principles of the patient-centered medical home model and integrated HIV care and behavioral health services. The practice transformation process involves goal setting, leadership, practice facilitation, workflow changes, quality improvement, and outcomes measurement, and adapting organizational tools and processes to support advances in models of team-based care. Long definition. But these are all really good things. It's patient-centered, it focuses on quality improvement, it focuses on integrated care and team-based care, it talks about behavioral health integration, which is really key in HIV care, and it wants to improve patient outcomes. This slide is going to walk you through practice transformation and then a subset of practice transformation called practice transition. And practice transition is a type of practice transformation that I've been involved in evaluating at Beaumont Baptist Hospital here in Texas. So practice transformation, again, is the HRSA term. And it's the idea that an AIDS services organization or an HIV specialty care clinic transforms its practice to become an FQHC. So the new patients that they take on may or may not have HIV. Remember, they are AIDS services organizations, so they have specialty care in their clinics, and then they're going to adopt a broader patient population. Practice transition is when a primary care clinic that's already experienced in primary care and in handling a general patient population starts to newly accept patients with HIV care. So the ultimate goal is the same, though, that HIV-positive patients receive holistic care in one place and have improved outcomes along the care continuum. Again, the main difference is in what they already know how to do. So an AIDS services organization or HIV care clinic is already experienced with HIV care, and they are experienced with Ryan White funding, which is the funding source for those who don't have health insurance and that are HIV positive. Becoming an FQHC means that they're going to have to think about new services, staffing, they're going to have to offer sliding fee discounts, they're going to have to do quality improvement, they're going to have to expand their access and their hours, they're going to have a board of directors, like I showed you in that very first slide, that comprises their patient population. So there's a lot to do when you become an FQHC or a patient-centered medical home. Primary care clinics, on the other hand, are very experienced at treating chronic conditions. They may already have a chronic care model in place or a patient-centered care model, but they're probably not familiar with HIV clinical care guidelines, HIV patient needs, the Ryan White funding requirements, and so they have a lot to learn as well. And they may or may not be an FQHC or lookalike, but that should be the ultimate goal. So let's take a minute to talk about why these new models, these emerging models, are needed in HIV care. This is a map from the CDC that shows the lifetime risk of HIV diagnosis by state. And you can see in the right-hand bottom side, Texas and the South that have the highest risk. Texas has the 7th highest risk of HIV diagnosis over the lifetime. This figure shows Texans living with diagnosed HIV infections on the orange line, new diagnoses on the blue line, and deaths to HIV in the gray line. And there are two things to take away here. The number of people living with HIV is increasing, and that's because there are new diagnoses every year and people are living longer as HIV becomes a chronic condition. The second thing to note is that HIV diagnoses are stable, so they're not decreasing. So that means every year more and more people are going to be living with HIV in Texas. Now, if we think of treatment as prevention, we need to test, treat, and retain people in care. People have to achieve viral suppression, both from a prevention standpoint as well as from a clinical outcome standpoint. This is a treatment cascade that shows Texans living with HIV and how they progress through the care continuum. So you start on the left with HIV-positive individuals living in Texas, and you can see that 23% of those that have HIV are not getting even one visit with a provider, so they're not linking to care. Those that do end up in care, 30% of them are being lost to follow-up, so only 70% are retained in care. And then 59% are achieving viral suppression. And so again, in terms of prevention and in terms of clinical outcomes, we need 100% viral suppression. Another thing to note is that there are shortages in primary care and in HIV care. Texas is currently number 47 out of 50 in the ratio of primary care physicians to the population in the U.S. Nationally, 50% of HIV providers will be retiring in the next 5 to 10 years, and Ryan White Part C funded clinics who specialize in HIV care report difficulty in recruiting HIV clinicians. We're now in the chronic disease era of HIV care, in which HIV is a disease to be managed as a chronic condition, and there are considerations for comorbidities and aging. We also know that HIV is one of many chronic diseases that patients are facing. So an HIV-positive patient could also be managing diabetes, cardiovascular disease, obesity, hypertension, and have behavioral health concerns. So thus is born the idea of the HIV primary care provider. So this provider manages both the primary care and the HIV care of a patient. And so it helps to deal with the shortage in the HIV workforce as well as the primary care workforce. I'm going to talk next about the current evaluation efforts surrounding these two. I want to start with just talking about the evaluation efforts of the patient-centered medical home. These were called the National Demonstration Projects, and they were conducted beginning in 2006 by the American Academy of Family Physicians. And they evaluated the implementation of the patient-centered medical home model in practices around the U.S. And they came up with these key findings, which I think are really relevant to any practice that's embarking on the practice of change. So practices can be facilitated or self-directed in their change. So if a practice decides that it's going to take on a new model, it can do it itself, but it also can be facilitated by a group of experts and mentors. There's always a need for external resources. That includes support, training, and facilitation. Clinics that want to embark on some sort of practice change need to have a strong core of individuals who are highly motivated and have adaptive reserve. And adaptive reserve is defined as an organization's ability to take in change and adapt and manage change. Another tenet is that roles and identities have to change within the clinic. So people have to take on new roles, new identities, new types of work, new types of workflow. And then you must consider the local environment. So a new model cannot be implemented in the same way across environments. And also that it takes a long time. So currently, practice transformation is being evaluated by the projects of national significance. And so these are HRSA projects. The current initiative is entitled the System-Level Workforce Capacity Building for Integrating HIV Primary Care in Community Healthcare Settings. And it's a multi-site demonstration project that evaluates the system-level changes in staffing to improve health outcomes along the HIV care continuum. In Texas, there are 2 sites that are actual projects of national significance and are currently being evaluated in a 4-year demonstration project. The 2 sites are the Special Health Resources in Longview and then the Coastal Bend Wellness Foundation in Corpus Christi. And so the idea is that they will implement and evaluate the practice transformation model that we talked about, and that will include task shifting. So that means shifting specific tasks from the physician to mid-level providers or other healthcare workers, restructuring of staff to meet the standards of the model, integration, which means including patient navigators and community health workers into the care team, and then co-management or team-based care coordination. So the idea that an HIV specialist will provide oversight and ongoing consultation to a generalist physician. So again, the idea that a primary care physician can coordinate HIV care for patients. In Corpus Christi, their project will provide integrated primary care, HIV, and behavioral health services using the health home model. And their goals include interdisciplinary team-based strategies, realignment of the agency workforce. They're using a team-based approach that includes primary care, HIV care, and behavioral health services. At Special Health Resources for Texas in Longview, they are actually an AIDS services organization serving people living with HIV, and they're in a rural area of northeastern Texas, and they're also developing an interdisciplinary team-based strategy. And their goals also include task shifting and physician extension. They're trying to increase the number of persons receiving HIV and primary care services together, so they're trying to integrate care services into the model. They're increasing the agency's ability to track, assess, and document project objectives, and they're developing an interprofessional, interdisciplinary, team-based approach. And this is a logic model I'm not going to go over. It has a lot of text on it, but something that you could look at later, and it basically sets out how the idea of the practice transformation model and how the activities that happen in the clinic setting go forward to lead to certain outputs and then short, intermediate, and long-term outcomes for the patients. So the last thing I want to talk about is how UTMB has evaluated the practice transition process at Beaumont Baptist Hospital in their Smart Health Clinic. A little bit of background on Beaumont Baptist Hospital's Smart Health Clinic is that in 2016, they're a primary care clinic. In 2016, they started to offer PEP and PrEP services to their clients. And at that time, they considered whether they could add HIV care because they were seeing many new patients. So they went under a discovery process that included all of the people on their care team. So physicians, nurse practitioners, social workers, linkage to care professionals, and then the grant writers. And they decided that they wanted to go forward. So in 2017, they signed a contract with the resource group, which is the administrative agent or the fiscal agent for Ryan White funding in the area. They expanded their office space to include additional exam rooms and private intake rooms. And then on May 18th, just over a year ago, they started taking HIV patients. And so I was there with a team from UTMB on that day when they first saw their HIV patients. And since that time, Dr. Kaiser here at UTMB and the team have facilitated learning collaboratives that are on-site, so they've done shadowing and on-site visits, they've done webinars, they've done conference calls for both clinical and administrative support, and then Dr. Kaiser and the UTMB team have been available and been on call for questions that the staff have. So remember, this is a primary care practice that started to take on HIV patients, so this is all new territory for them. So our evaluation included key informant interviews. So we were on site and did follow-up phone calls with the Smart Health Clinic staff. They also included interviews with Department of State Health Services of Texas and UTMB staff. It also included literature and information reviews, including research, theory, models of care. And then one important point is that this was mostly a process evaluation, so we're really focused on implementation, and we have not focused on outcomes at this point. And these are the considerations that came out of that evaluation effort. So there's 6 considerations: clinic model, funding, logistics, costs, staffing, and patient needs. And so none of these are that earth-shattering, but this is all new territory for this clinic, and so there were some really important questions and considerations that came out of the discovery process. So these 6 considerations are set out so that clinics can use these as questions to ask themselves as they go through a process of practice transition. So if a clinic were to embark on the process of taking in HIV patients, these are questions and considerations that they would want to address. So the first one is clinic and care models. If you're an FQHC or a lookalike, you have certain structures in place. But if you're just a primary care clinic that doesn't follow a certain model, it's important to address whether you have a chronic care model in place, whether you're practicing patient-centered care, are you seeking to transition to a patient-centered medical home? Do you have a collaborative care model? So the model that you have in place or the model that you're seeking to transition to is really important to consider. And some sample questions would be, how does our clinic model affect our staffing, the logistics, costs, and funding of transitioning to taking on HIV patients? And how do we need to adjust our model of care to meet HIV patient needs? The second consideration is funding. So funding sources can be grants, charity care, Medicaid, Medicare, Ryan White funds, or private insurance. So some sample questions could be, is it possible for my clinic to secure Ryan White funding? If I do have Ryan White funding, how do I account for Ryan White patients and privately insured patients in Ryan White grant reports? In a fee-for-service model, how will I account for activities that are not direct patient care? So funding is one of those crucial considerations in practice transition. Number 3 is logistics. These are the day-to-day operations of the clinic, including the recruitment, scheduling, intake, office space, and co-location of services. So important questions to ask could be, what days are we going to have Ryan White patients come for intake appointments? So if you know anything about Ryan White grants, grant funding, patient intake appointments are a long process and there's a lot of paperwork to fill out. So staff would have to set aside specific time for that. You also need private intake rooms where you can meet with patients individually to do the intake paperwork. Another question would be, what times are staff going to provide follow-up or medical case management for HIV positive or Ryan White patients? So some Ryan White patients are referred to medical case management and require a lot of ongoing follow-up, and that's extra time that staff have to use on the phone or in person with their patients. Another question would be, what kind of quality improvement tools and processes are we going to use? So Beaumont Baptist Hospital really struggled with how they could do an ongoing quality improvement process within their clinic so that on a weekly basis they could address things that were happening because of their transition. And then another question would be, do we have the office space or the staffing to co-locate services? So Beaumont Baptist Hospital was really lucky. They have a pharmacy on site. They also have a social worker. But another consideration would be, do you have behavioral staff that can provide counseling? Do you have someone that can prescribe medicine? Do you have somewhere that patients can go and pick up their medicine that's really close by? Because remember, anytime there's a gap in service or patients have to travel, you could have fragmentation of care. The fourth one is costs. So how are staffing and resources going to be used? And so sample questions might be, how much time are we going to spend preparing for patient encounters? How much time can I spend with each patient? How much time is there for case reviews? And even weekly case meetings where all of the medical providers on the team meet together. How much time do I have for charting and paperwork and documentation? Because there's a lot of it with Ryan White funding. And what are the other costs? Are there supplies, equipment, materials, facilities, utilities that are going to increase in cost by taking on extra patients? The fifth one is staffing, and that was closely tied to logistics and funding. And so sample questions might be, are there gaps in staffing in terms of quantity and the type of staffing? Is there a new type of staff member that we need to hire in order to meet the need? How many Ryan White or non-Ryan White patients can I take on a caseload? Which staff for which patients? So which staff are better equipped and a better fit for some patients? Who's going to do the medical case management? What kind of staff training do we need? When can we do the training? And who can be our mentor along the way? These are a couple mentorship models from a larger table. They really speak, though, to the process that Dr. Kaiser and UTMB facilitated with the Beaumont Baptist Hospital Smart Health Clinic. And so the first one is the co-management model. It's when an HIV physician visits a clinic to discuss difficult or complicated cases with the new HIV primary care provider, and then uses hands-on training to improve the quality of care. And so that's what UTMB and Dr. Kaiser did in the early stages of the transition. And then phone or telementoring is another great way. So they did weekly calls with Dr. Kaiser or an HIV physician. And then the HIV physician is on call by phone or by Skype to answer questions as needed, especially in complicated cases. And the last consideration was patient needs. So the page on the right is from the Guide for HIV/AIDS Clinical Care. And it's an overview of the clinical considerations for patient needs. So their complaints, their comorbidities, including co-infections and complications, interactions with antiretrovirals, and then the competing priorities of both the patients and the providers in terms of their health care. But beyond the clinical, there are other considerations that patients with HIV have. So are your patients new? Are they continuing? Are they re-engaged after a loss to care? What other kinds of social services do they need? Do you need to make referrals? Do you need to form partnerships in the community with other organizations in order to assist in their care? What kind of behavioral health needs do they have? Do you have those services on site, or do you need to refer out? Do you have health education? Do you have lifestyle and social support? And then thinking about if they're from a subpopulation or a gender minority, what specific needs do the subpopulation have? This is a list of some key resources identified by Beaumont Baptist Hospital during their process, and they'll be available to you later. And so finally, we get to next steps. Where are we going from here? And so the first picture in the top left is of Texas. So thinking about where else in Texas can practice transformation and practice transition occur. So as we saw in the slides before, in practice transformation, there are 2 demonstration sites, projects of national significance in Longview and Corpus Christi, and then there's the practice transition site in Beaumont Baptist Hospital. But where else in Texas can this happen? What other clinics are willing to embark on this process of change? The next picture of the HIV treatment cascade and of the HIV care continuum is considering how primary care and HIV care can fit into the HIV care continuum. And so what other services need to be offered in the clinic so that we can bring people from testing through treatment to the retention and care up to viral suppression? And then considerations of telehealth. How can telehealth be integrated into primary care clinics and HIV primary care practices? And the last is to evaluate. So every practice should be constantly evaluating not only the process of transitioning and the process of their care, but also the outcomes. There's always a little bit of money and a little bit of time to evaluate. It could be as simple as surveying patients in terms of their satisfaction of care. These are the references for the slides. And now I'm available for any questions. Yeah.
So exactly what roles does the Ryan White Foundation play in all of this? You brought it up a lot.
Yeah.
So what all exactly does the Ryan White Foundation
So the Ryan White funding is federal government funding. It's a payer of last resort. So if a patient has no other health insurance, then Ryan White funds can be used to pay for their care. But
specifically like for HIV patients?
Yeah, it's specifically for HIV patients, right. So you can have patients that have HIV that have private insurance, and they can go to an HIV specialist or they can go to a primary care provider. But if you're an HIV positive patient who doesn't have insurance, you have to seek out a clinic that accepts Ryan White funding. So those are limited. Like where I'm from in Austin, there's only one that has Ryan White funding. So if you're an HIV patient in Austin, you can only go to that specific clinic. So that's one of the issues.
That Ryan White Foundation patients can actually find health care that, not rare, but
it's harder. They're usually, yeah, it's obviously much easier if you have Medicaid, Medicare, or private insurance.
Is there a reason that if you know that a lot of like healthcare providers and hospitals and clinics don't take Ryan White patients? Is there a reason for that?
The issue with Ryan White funding is that it comes through the state of Texas, and then it's dispersed through administrative agents in the state of Texas, and so those administrative agents form relationships with clinics or service organizations that are under contract to provide the services. So there are a lot of steps involved in becoming a Ryan White grantee. And so I think that probably with all of those steps lead to, it's difficult. It's a long process, yeah. So with Beaumont Baptist Hospital, what's interesting and what really helped them in their process is that there was a gap. So an organization that previously had Ryan White funding in Beaumont lost their funding, and so that funding was sitting there, and Beaumont Baptist Hospital was actually able to come in and fill, and they signed the contract with the resource group, which was the administrative agent in that area of Texas. And so the fact that Ryan White funding was there was immensely helpful. Otherwise, they could have seen HIV patients, of course. That's up to a practice they can accept, but whether they would be able to serve patients who couldn't pay, that's the other question. So by accepting Ryan White funding, by having it, they can accept more patients. Yeah.
So how often do HIV patients have to come into the clinic? Like, is it a monthly thing?
I think
clinic provide that support?
So for uncomplicated patients, it can be managed like a chronic disease. So I'm not an expert on HIV care by any means, but for a patient who is tested and then comes in and has an uncomplicated case, they can probably be managed outside of medical case management and just do follow-up with a provider. I'm not exactly sure how often is required. But those who come in at late stage of diagnosis or have been lost to care and haven't been on medication or have co-infections and comorbidities, those cases become much more complicated. And so even in the model that Beaumont Baptist Hospital is using, they are constantly referring patients to an infectious disease specialist or to an HIV care specialist or out to a specialist that can handle, that can address their specific needs. But for an uncomplicated case, it could be the same as someone who has diabetes. And so they come in as needed and they follow up and they fill their prescriptions and they only come in when they really need to address something. Yeah. Yeah.
How did the patients in Beaumont find out about the clinic?
So it's a fairly small community there, and when the organization that was previously funded was no longer funded, the other organizations in that area said, hey, Beaumont Baptist Hospital is taking on this role. They're filling the gap, and they're going to be accepting patients. So they really put the word out in the community that this was happening. And, they only saw, I think we saw 4 patients that day, and their goal is to get up to 200 patients. So a lot of it is word of mouth and just being in partnership with other organizations in the community that are part of the HIV positive community and just getting referrals by word of mouth, yeah.
About what percentage of those people moved from the old clinic to...
I'm not really sure, actually. Yeah, that's a good question. Any other questions? Yeah.
So you said that the Beaumont Baptist was the primary?
Yeah.
Or they transitioned into a lookalike?
No. They're a primary care practice, and then they transition to taking on HIV patients, and then they're in discussion about whether they want to become a FQHC or lookalike. So the FQHC process, if you want to actually receive funding from the federal government, is a really long process with a lot of steps. Lookalikes can do it, but they don't receive the funding. So again, there's just a lot of considerations. It takes a lot of leadership and organizational support for a clinic to transition to that. So I think that's the ultimate goal, because at this point, because of funding, they still have to refer people out to outside services. But if you're an FQHC, you can treat the whole person within the clinic and be reimbursed for all of the care. So it's a long process. Like, if you look on the websites for organizations that help FQHCs or clinics transition to becoming FQHCs or lookalikes, it can take 1 to 2 years minimum to really transition. And Beaumont Baptist Hospital, I think their Smart Health Clinic still feels like they're a year into this process of just taking on HIV patients, and they're just still learning. You just have to be patient. It takes a long time for your system to adapt to all these changes. I think that's been one of the criticisms of some of these models, is that they're put out like this is what you should do, but then the practical implementation is what's so difficult. And so our ongoing evaluation with Beaumont Baptist is that we really want to figure out what are the do's and the don'ts of the process, and what are some key considerations, and what are some practical questions that a clinic can ask of themselves as they go through the process.
Thank you.